Our third speaker today is Professor Kuwana from the Division of Allergy and Rheumatology, Nippon Medical School in Tokyo, Japan. Professor Kuwana just gave us a talk regarding CTD-ILD, the progressive and advanced treatment yesterday. And he has been in our annual meeting for so many times, and I believe he is someone required no introduction. And today he is going to give us a talk regarding Japanese guidelines for diagnosis and management of CTD-ILD to 2025 update. Let's welcome Professor.
Thank you. Good morning. First of all, I'd like to thank Professor Chang and board member of the TCR for giving me an opportunity to give a lecture here in June. I'm always grateful to the heartful hospitality of colleagues and friends in Thailand. I'm going to talk about the Japanese guidelines for CTD-ILD, which was just recently updated. These are my disclosures. Already mentioned, ILD is a substantial morbidity and mortality marker with many tissue diseases. So over the past years, many consensus statements and guidelines have been developed based on evidence-based expert opinions. Since the first publication of Japanese guidelines in 2020, there are many guidelines consensus statements have been developed. This year, the Japanese guidelines have been updated, and also ERS ULA guidelines have been released. Among those guidelines, a distinctive feature of the Japanese guidelines is that they propose statement of separately for acute, subacute, ILD, and chronic ILD. The 6 phenotypes based on disease behavior are proposed as shown in this slide. This framework helps us align therapeutic indication and choices. This is a management algorithm proposed by Japanese guidelines. This consists of sequential steps including risk factor assessment, screening, diagnosis, severity assessment, assessment of progressive risk, treatment, and finally follow-up and monitoring. My lecture follows this clinical flow. The first step of the clinical scenario is a risk factor assessment and screening of ILD. This meta-analysis shows that ILD is particularly common in SSC, myositis, and MCTD. The prevalence is over 50%. On the other hand, the frequency of ILD is less than 20% in RA, Sjögren's disease, and lupus. This difference in the prevalence of ILD significantly impacts the decision to implement screening program. This is a screening program for ILD in CTD patients proposed by Japanese guidelines. If patients' symptoms or signs suggestive of having ILD, diagnostic approach to chest HRCT should be applied directly. In case of lack of symptoms or signs, whether to conduct screening or not should be decided based on the risk factor shown on the slide. ULA-ERS guidelines recommend that all patients with SHC and MCTD should be screened for ILD using HRCT, irrespective of the signs or symptoms of ILD or ILD development risk, because of high prevalence of ILD in this patient population. In our patients, these factors described in guidelines are somewhat different. But older age, male sex, smoking history, and high titers of positivity consistent. In addition, RA disease activity as a risk factor for ILD development has been attracting attention recently. For example, in this cohort, more than 1,400 RA patients without ILD at baseline. Increasing DAS28 scores correlated with higher hazard ratio for incident ILD development. These data shows that higher RA disease activity is strongly associated with the future development of ILD. We now move to the diagnosis. All guidelines strongly recommend the use of chest HRCT for diagnosis of ILD. Japanese guidelines claim that multidisciplinary discussion, including pneumologists, is considered for differentiating CTD-ILD from idiopathic interstitial pneumonias. Of course, bronchoalveolar lavage should be considered for diagnosis by exclusion of other etiologies, including infectious disease or alveolar hemorrhage. After diagnosis of ILD was made, the next step is assessment of ILD severity. In the Japanese guidelines, chest HRCT and forced vital capacity by pulmonary function testing and their combinations are effective for assessment of ILD severity. In patients with SSILD, Japanese guidelines recommend use of a single staging system for evaluating ILD severity. This system classifies the patients into limited and extensive disease based on ILD extent of chest HRCT. And FVC is used when the ILD extent is indeterminate. A 5-year survival rate in patients with extensive disease was lower than 50%, clearly indicating the requirement of the treatment in this patient population. The staging system using ILD extent of HRCT and FVC is proposed for evaluating the severity of RA-ILD as well. Unlike the system for SSILD, patients in the bad-acting group are further classified based on the presence or absence of UIP pattern on HRCT. Even in ILD with mild severity, assessment of progression risk is necessary to decide treatment indication. The clinical course of CTD-ILD is extremely heterogeneous. Some patients present with acute or subacute onset and deteriorate rapidly, while others show slow progression or even remain stable for years. Acute exacerbation can occur at any stage and often lead to respiratory failure and mortality. This variability is a major challenge in optimizing the management in patients with CTD-ILD. In Japanese guidelines, as I said before, the management begins by determining the onset pattern, acute and subacute versus chronic. Acute or subacute ILD require the treatment with immunosuppressive regimen. On the other hand, chronic ILD is stratified into mild versus severe disease and into low versus high risk for progression. High-risk cases were earlier introduction treatment, whereas low-risk patients may be monitored closely. First, I will focus on the acute or subacute ILD typically seen in patients with myositis. In this Japanese registry of myositis ILD, almost all patients were treated with glucocorticoids, and half of them received additional immunosuppressant. Despite this, 93 patients died during the observation period of a median of 3 years. The major cause of death was respiratory failure due to ILD, which was found in 81% of the deceased cases. A short-term cumulative survival rates are both in patients with anti-MDF5 compared with other patient groups. Importantly, the majority of deaths in this patient population occurred within 6 months after diagnosis. In this cohort, multivariable analysis identified independent initial prognostic factor for mortality due to respiratory insufficiency, including older age at onset, anti-MDF5 antibody positivity, increased CRP, and oxygen desaturation. However, anti-MDF5 positive patients do not necessarily have a poor prognosis. These cluster analyses revealed at least 3 clinical phenotypes within anti-MDF5 positive patients, including a subset with rapidly progressed ILD, with poor treatment response and early mortality. The proportion of the poor prognostic subgroup varied among the cohorts, ranging from 18 to 32%. This heterogeneity requires development of predictive model within the anti-MDF5 populations. While multiple prognostic models have been proposed in anti-MDF5 ILD, most are from mainland China, few are externally validated approach-dependent cohorts. So we await the reproducible model combining indicators that can be used in clinical practice. I now move to the treatment of myositis ILD. The ACR chest guidelines recommend mycophenolate as a cyclin and reduction, which were in fact common among all CTD-ILDs. The options unique to myositis ILD include a calcineurin inhibitor and a JAK inhibitor. The important message here is short-term use of glucocorticoid, which can be possible by initial combination with immunosuppressant. The ACR chest guidelines propose recommendation for patients with rapidly progressive ILD. Pulse intravenous methylprednisolone was conditionally recommended as first-line treatment, followed by upfront combination with one or more immunosuppressive agents. Especially triple combo therapy was recommended for those with confirmed or suspected with anti-MDF5 ILD. For treatment of anti-MDF5 ILD, triple combo therapy consisting of high-dose glucocorticoids, intravenous cyclophosphamide, and tacrolimus maintained at a high drug level is widely used in Japan. But the evidence is very scarce. In this single-center study, all consecutive patients with anti-MDF5 ILD were treated initially with triple combo therapy. A short-term survival rate was better in this patient population than in historical controls treated with the step-up strategy. However, serious infections are common with upfront combination therapy. So appropriate prophylaxis and monitoring of infection are mandatory, and prompt initiation of treatment against infectious agents is essential. electronic combination are also recommended, emphasizing the personal medical approach. It is of note that the plasma exchange is conditionally recommended for treatment of rapidly progressive ILD. The plasma exchange is increasingly used in the treatment of rapidly progressive ILD, especially those going to find TCR. In these systematic reviews of the 6 cohort studies involving patients refractory to standard treatment regimens, adding plasma exchange to intensive immunosuppressive regimen may improve 1-year survival, particularly in those with anti-MDF5. So Japanese guidelines recently released recommend the triple combo therapy for rapidly progressive ILD. This emphasizes adequate timing of therapeutic intervention in patients with multiple structure, especially those with anti-MDF5 patients. Notably, in anti-MDF5 positive rapidly progressive ILD, plasma exchange is considered within 2 weeks after initiation of therapy when treatment response is inadequate. This is very unique to the Japanese guidelines. We now move on to the chronic ILD. In CTD-ILD, up to 40% of the patients with chronic ILD have progressive pulmonary fibrosis or PPF and poor survival. In many patients have stable disease and do not require specific treatment for ILD. It is obvious that the best timing for treatment introduction in patients with PPF is early in the course of the disease, before deterioration of primary function. To make this possible, we need to predict future course of ILD in patients with limited or subclinical ILD. Proportion of patients with PPF are variable among underlying CTDs and ranging from 16 to 40% according to this review paper. For SSC and RA are 2 major CTDs with high prevalence of PPF. This cohort study showed that the initial FVC decline in SSC-ILD does not predict future ILD progression at the next annual visit. Interestingly, patients who have already experienced progression were less likely to progress again after adjusting for non-risk factor and treatments. However, FVC decline at any timing was associated with increased mortality risk. So these findings highlight the unpredictable, non-linear behavior of SSC-ILD and the need for continuous monitoring even in the subclinical mild ILD. In patients with SSC-ILD, many risk factors for predicting ILD progression have been reported. These include risk for subsequent FVC decline or poor prognosis, high level of KL6 at baseline, increased ILD extent on chest HLCT, low diffusing capacity, reported as risk for predicting the subsequent FVC decline and poor prognosis, high skin sickness score, and SPR model, which is based on the oxygen desaturation after 6 minutes walking test, and the presence of history of arthritis are useful to predict short-term FVC decline. The most reliable predictor for ILD progression in SSC patients is the entry criteria of phase 3 clinical trial of Sulisma, which enrolled patients with early diffuse transensation with active skin disease and elevation of inflammatory markers. The patients assigned to the placebo group experienced the rapid decline of FVC over 48 weeks. So main drivers for treatment initiation in patients with SSc-ILD include ILD extensive disease, early diffuse cutaneous subset, and elevated inflammatory markers. These statements were described in Japanese guidelines. How about the progression trajectory in RA-ILD? This Korean multi-center prospective cohort of RA-ILD patients reported four distinct FVC trajectories: improving, stable, slowly declining, and rapidly declining. Importantly, about half of the patients experienced progressive course. These findings highlight the heterogeneity of RA-ILD behavior, and many of the patients with RA-ILD require treatment. Recently, there are accumulated evidence showing that RA disease activity is associated with subsequent ILD progression. In this prospective registry, higher disease activity, like DAS28, or impaired functionality measured by HAQ, predict ILD-related mortality, and DMARS treatment reduce the risk of mortality. So controlling the disease activity is important to prevent progression of ILD in patients with RA. I'm sorry for the very easy slide, but this is the drug treatment algorithm for RA-ILD proposed by the Japanese guidelines. For chronic ILD, management of symptoms to achieve remission for low disease activity is the first line of treatment. So actually, the first line treatment of RA-ILD needs to control the arthritis. The monitoring and follow-up of ILD is aimed for two purposes. We monitor ILD progression in the treatment-naive patients to decide if treatment is necessary. Alternatively, we monitor ILD progression after introduction or change of the treatment to evaluate the treatment response. In the Asia CHEST guidelines, pulmonary function testing, ambulatory saturation testing are recommended to monitor ILD progression. The suggested frequency of pulmonary function testing vary by underlying disease and risk of progression. Usually every 3 to 6 months for the first year and less frequent once later. These guidelines pointed out the utility of chest HRCT in monitoring ILD, but suggested HRCT when clinically indicated and needed. On the other hand, Japanese guidelines recommend combined assessment of chest HRCT and pulmonary function testing in evaluating progression of ILD. HRCT is rather given priority over pulmonary function testing and should be considered in conjunction with scale 6 and SPD measurement. This is consistent with the Euro-US guidelines, which suggest repeating pulmonary function testing every 3 to 6 months for the first year and repeating HRCT after 1 to 2 years in patients with progression risk. In SSc-ILD patients, frequency of pulmonary function test, HRCT, oxygen desaturation test, and patient-reported outcomes are decided based on risk of progression and disease duration. But most of these recommendation evidence not supported by the evidence, just generated by expert opinion. So we need to validate these recommendations in the future. Japanese guidelines recommend use of PPF definition as a progression from ILD. progressive ILD is defined as at least two of the physiological and radiological evidence of progression promoting respiratory symptoms. But recently there are a lot of discussions about the utility of chest HRCT alone over QFT condition, because there are high variability of QFT results, and also the patient-reported outcomes is not sensitive to enough the minimal changes. This is the treatment algorithm for SHILD. The treatment indication include patients with extensive disease but without end-stage lung disease, and those with limited disease who have high risk for progression or who experience ILD progression during the follow-up. In case of treatment indication, the next decision making is the choice of pharmacologic therapies. This slide summarizes initial and secondary treatment selections for SHILD recommended by guidelines. Mycophenolate, cyclophosphamide, tocilizumab, rituximab, and nintedanib are recommended across all guidelines as the first-line treatment. Japanese guideline, ATS guideline, and Asian chest guidelines recommend mycophenolate monotherapy as the preferred first-line treatment because of a good balance between efficacy and safety. In case of stabilization, first-line treatment should be continued. In case of progression of ILD despite first-line treatment, add-on or switch of the treatment options are recommended. Upfront combination is suggested in the guidelines, but evidence to support this is completely lacking at this moment. In the census trial, 48% of the patients were taking mycophenolate at baseline. The effect of nintedanib in preventing the FVC decline appears greater in patients who are taking mycophenolate, supporting the sequential combination of nintedanib on top of mycophenolate in patients with SHILD. The ERS guideline proposed the almost same treatment approach, but showed the guidance to choose a treatment regimen based on extrapulmonary involvement, early diffuse SSC with sign of inflammation, and lung fibrosis extent. A notable point is to recommend upfront combination of nintedanib and mycophenolate or combination with suppressants, such as mycophenolate plus rituximab or tocilizumab for patients with high risk for progression. Japanese guidelines propose draft treatment algorithm for RAID. This treatment algorithm has a draft on top. This means that there are many inconsistencies among the experts in Japanese societies. So this is a tentative algorithm. So these will be updated in the future. But I think the important point which is the consensus is talk. So in chronic fibrosis ILD, this guideline emphasizes the importance of controlling this activity by demons, especially methotrexate may be considered if the patients do not have extensive progressive ILD. If arthritis remains uncontrolled, addition of viral demons like JAK inhibitor is conditionally recommended. Among viral demons, abatacept and rituximab may be preferred option due to their relatively favorable safety profile in patients with ILD, not based on the efficacy. In case of ILD progression despite well-controlled arthritis, escalation of immunosuppressive therapy is recommended for inflammation ILD, while in fibrosis dominant ILD, the typical UID pattern, antifibrotics may be preferred. The ACL chest guidelines recommend mycophenolate, azacitidine, and rituximab as preferred first-line treatment for RA and ILD. But I want to emphasize that no randomized controlled trial have been conducted for RA. But this multi-center retrospective study using prospectively enrolled ILD patients showed the use of azacitidine, mycophenolate, rituximab potentially prevent decline of FVC or diffusing capacity. In contrast, the antifibrotic internet have some evidence to support use for RAILD. The induced subgroup analysis of original ILD, the rate of FVC decline over 52 weeks was consistently sure is internet compared with placebo across underlying CTDs, including the RAILD. Although this was post-hoc analysis, this justifies use of internet in progressive fibrosing RAILD. In patients with RAILD, acute exacerbation is associated with mortality. In the INVIEW trial, internet prolonged time to first acute exacerbation death compared with placebo. Same trend was observed in subgroup analysis of autoimmune ILD and RAILD. In URIER's guidelines also, this proposed the treatment ILD in RA patients. It emphasized again that all patients with RAILD with presence of active arthritis requires treat-to-target approach of controlling disease activity. In case of patients with well-controlled arthritis, choice of immunosuppressants and antifibrotic agents are decided based on the severity of ILD, PPF development or not, and the HRCT pattern, whether you are here or you are here. So this is the summary of my talk. So the Japanese guideline is just released, but there are many new papers publishing. So these guidelines soon be getting old. So we need to update the knowledge on management of CTD-ILD. And the Japanese guidelines provide the structure guidance for identifying and evaluating the monitoring and management of ILD across CTD. So this is friendly to our clinical practice. Some inconsistency remain among international guidelines, probably due to difference in experience and test availability, drug approval status, and most importantly, the reimbursement system. Importantly, the evidence base is still limited, highlighting the need for future research. The English version of the Japanese guideline is scheduled to be published early next year, so please wait a little longer. So thank you so much again for your attention, and I'm happy to take questions.
Thank you. Thank you, Mr. Kuwana, for the very important talk on Japanese new guidelines. So are there any questions from our audience? Yes, please. Please introduce yourself.
Yes, Kuwana, from Masaraka Hospital. Thank you for a comprehensive talk and the introduction of the new released Japanese guidelines. Quite fascinating in the algorithm in treating myositis ILD that you suggest the plasma exchange in anti-EF5 positive patient with rapid progression. And also found in the middle of the algorithm that if there is negative on anti-EF5, the committee suggests using IVIG for their rapid progression. Is there support of evidence or Japanese experience in the difference between choosing IVIG or plasma exchange in your community, and I'm curious about the availability of IVIG or plasma exchange in your experience. Thank you.
Okay. So in patients with rapidly progressive ILD associated with anti-inflammatory, because the clinical approach is very devastating. In that case, randomized clinical trial is not possible. So the data we have are based on the retrospective analysis. So the evidence level is very, very low. In terms of IVIG, the several papers report the efficacy to reduce the mortality in the course of the anti-inflammatory ILD, but almost all patients receive other treatment in combination. So it is very difficult to evaluate the efficacy of IVIG alone in this patient population. But IVIG may be used to prevent the severe infection during intensive suppression. So in most Japanese centers, we use IVIG in a refractory case, and also patients very low IgG in levels, and already experienced the severe infection. So in our country, we use IVIG for two. But from the exchange, the pathogenic mechanism of anti-inflammatory ILD is a cytokine storm, and anti-inflammatory antibody is also involved in the pathogenic process. So theoretically, the plasma exchange remove the cytokines and anti-inflammatory from the bloodstream. So that will suppress the progression of disease. But many previous studies use the plasma exchange in the later phase of disease. In that case, all the paper didn't see any efficacy. But in our country and in our guidelines, we recommend to use the plasma exchange early in the course of the disease, within 2 weeks after introduction of treatment. So in that guideline, we created this recommendation based on the single center study. But now it appears that the early introduction of plasma exchange may reduce the cases, especially early in the course of disease in this patient population. Unfortunately, plasma exchange is now reimbursed by health insurance in Japan, and IVIG is reimbursed for the treatment of myositis. So as far as the diagnosis of myositis, IVIG is also reimbursed.
And regarding the combination therapy, in your experience, would you like in really rapid progression and refractory cases to combine both immunosuppressant IVIG plasma exchange followed by IVIG or in reverse? And if you do so, what would be the time interval between plasma exchange and IVIG in your experience?
And usually we use IVIG in the later course. So we use plasma exchange early in the course of the disease, and then we use IVIG at 3 months after the treatment introduction. So it is like to supplement the IgG to prevent the serious infection. That is the main purpose. So before use of plasma exchange, we used IVIG in early course of disease, but we didn't see any efficacy.
One last question, Professor Chen.
Yeah, and thank you for your nice talk. And how about the use of allogeneic stem cell therapy in refractory and progressive fibrosis CTD-ILD, even after treatment with anti-fibrotic agent and immunosuppression agent? Thank you.
You mean the hematopoietic stem cell transplantation or CAR T-cell therapy?
No, and allogeneic mesenchymal stem cell therapy. Yeah.
Actually, in Japan, this kind of treatment is not available. So now we start the autologous CAR T-cell therapy for early progressive myositis, including the myositis side. This is part of the clinical trial. So there are many restrictions. So probably only a few patients are eligible for this advanced social. But I have a question for you. So mesenchymal cell transplantation is available in Taiwan?
In clinical trial. And another short question. Consider the CMV reactivation is frequently occur after intensive immunosuppressant agent. Yeah, and do you recommend the CMV and prophylactic therapy for CMV infection?
Yeah, so we monitor the CMV anemia every 2 weeks for the patients under intestinal suppression, and if there was the detection of CMV anemia, even in a very low range, we start the treatment.
Thank you.
Because of the time limitation, I have to close this section. And let's give a big applause to Professor Kuwana. Thank you. Thank you very much. And I'd like to give the microphone up